PA pressures, posterior-anterior pressures. We've talked a lot about these this morning, and we've talked a lot about these through the course. And it's important that we use these in a way that's consistent with both good clinical experience and also with what the literature is telling us. We understand from the literature now that it's impossible to confine a PA pressure to one segment. We know now that if we apply a moment through the PA, that all segments of the lumbar spine will move, and they will move into extension. We know from the research that we have not been proven to be especially good at determining which level is stiff in relation to the others in terms of intra and inter-rater reliability. We have been able to be shown to be fairly reliable, though, in determining the stiffest segment in the lumbar spine, regardless of what it is, without putting a name on it. We've also been shown to be extremely effective in being able to determine a painful segment, particularly when the patient provides a verbal response or a verbal indicator of such a segment. So there's actually three ways to use the PA, and we'll go through these in sequence. It's important to make sure that the patient is in a comfortable, relatively neutral position. Ideally, we'd have a hole for the patient's face in the table. If not, we just need to do something that will take his face off the ground, allowing him to still breathe, which is an important human function. We'll make sure also that I do want him to have a relatively neutral cervical spine position. I don't want the patient to be rotated side to side, because that does have some effect on the fascia and the tissue and can bias the results that we're trying to get. I've also, in this case, got a pillow underneath the patient's belly to ensure that we're in a relatively neutral lordosis. I don't want the patient in too much extension. And I've got something under his ankles here. It is not comfortable to lay down with your ankles in a forced plantar flexion position for too long. Any of those factors, if taken away, will cause the patient to not be relaxed and can introduce muscle spasm that we don't really need when we're doing these techniques. The pisiform bone and the hypothenar eminence of the hand is the area here that we'll use for our pressures. You can use the left arm or the right arm. It doesn't matter. It just depends what your preference is from side to side. I, in this case, am on the left side of the patient. It doesn't matter which side of the patient you're on. Typically, if I'm on the left side, I'm going to be more comfortable using my right hand. Again, the table will be at a height that allows you to be at about mid-thigh, so that when you're doing the techniques, you're not having a hyperextended straight elbow. You want there to be a reasonably normal amount of flexion in the right arm. The first way we'll use the PAs is just as a very basic spring test. And this spring test is a very gentle posterior-anterior pressure in an inferior direction, just to give a little stimulus to the spinous process. And what we'd be looking here for is spasm. We're looking for a segment that's overly reactive and a segment that might delay some further attention down the line. It's also a segment that we want to avoid doing a deep pressure to, because it may induce some pain that otherwise wouldn't be there. The second way we'll use this is just as a general PA stiffness, to just get an idea of the initial resistance, understanding, of course, that the studies have shown now that resistance begins as soon as we start applying pressure. So it's R1. Then we're going to press down to R2, just looking for that end feel, so that we can not only find the end feel and its relationship to the other segments, but also be able to describe that end feel. Now I'm getting a couple of different end feels in Brian. Initially, I got a nice capsular, solid end feel as I went through the L1, L2, L3, and probably started even higher than that. But I get down to his mid-lumbar spine in the L3-4 region, the end feel is changing to something that's a lot softer, and then even at the end there's a little bit of muscle spasm right at the end. So I'll note that down and move on and go through all five of the segments that way. The last way that we can use this PA is as a stress test. The stress test, I want to develop slightly different position, straight onto the patient. I'm going to change to my left arm in this point. And this test will be a very slow, gradual pickup of resistance, and then slowly pushing through until that point where the patient either describes pain, there's muscle spasm, or you hit that hard capsular end feel. And this is more of a stability test, trying to get an idea of the overall translation, pure translation of the segment, as opposed to the physiological movements that would be associated with extension. So we'll use that technique in that basis. three ways of doing the PAs. The second way in particular, which is more than just the typical PA, is also very useful as treatment. And the body position is what changes when you use these as a treatment. If I wanted to bias the patient more into extension, I can remove the pillow, I can bring his legs up even further. If I wanted to bias this into flexion, I obviously could add more pillows or consider doing the technique in a chair or taking some things away from the legs. And likewise, I can add some side flexion simply by moving the patient's lower extremities, his upper quadrant, or just shifting his middle across to the side. And that all allows us to place these PAs into specifically different positions based on the movement that we're trying to increase.